You can go live now.
Good evening, everyone. It's a wonderful evening, and we have gathered over here for a wonderful webinar. In fact, we at Hetero Healthcare Limited are conducting consistent scientific activities, physical CMEs and conferences, and now on digital platforms since the COVID-19 pandemic has hit. And when we mention COVID-19, it's important to mention the tremendous efforts put by Hetero Healthcare Limited to bring India's first remdesivir brand with COVID-4 in India, and we have treated more than 2 million patients by now. We also developed favipiravir in also launched tocilizumab, which was need of the hour because only one brand was available. Most importantly, in the recent time, we also developed molnupiravir. We completed the Indian clinical trial, and we are glad to tell you that and inform everyone that in the recent CROI, in the last couple of days, this paper was presented and was accepted and presented by our research team. Earlier to COVID-19 pandemic, if you look at the Hetero's work, it has been instrumental right from the HIV pandemic. We have worked extensively over there. We were one of the first company to launch antiretroviral drugs. In anti-HBV, we were there. Bird flu, the oseltamivir, we were the first company, and we have always ready with the stockpile required for any epidemic if it arises. Anti-HCV as well. And in the recent pandemic also, the Hetero has proven its mettle. What is important, the oral industry, pharma industry, is getting changed due to new molecules and all. And the industry is also being guided by the doctors, and they have witnessed tremendous success in biosimilars. In fact, many various autoimmune diseases are being controlled by various drugs like JAK inhibitors. And those are the need of the hour as well. And in biosimilars, when we talk about, we were among the companies who developed rituximab in-house, adalimumab, bevacizumab, dabopoetin alpha, and recently we have added tocilizumab in our kitty. And when we talk about newer classes of drugs like JAK inhibitors, which have been successfully used in various autoimmune diseases, they are also being explored in dermatological conditions. Thus, this webinar has been carefully crafted with an expert panel on board to address the use of JAK inhibitors in dermatology. To navigate us through for this next 2 hours, for this event, we have our moderator with extensive experience in dermatology, and is one of the most experienced clinician in dermatology, DG Saple sir. Can I have his slide, please, Vijay? To talk about Dr. DG Saple sir, his CV, everybody knows him quite well throughout pan-India and also globally. Dr. Saple sir is a former honorary professor in head dermatology, venereology, and leprology, Grand Medical College and Sir JJ Group of Hospitals, Mumbai. He is involved in clinical management research and training program on HIV/AIDS for last 30 years, published many international papers, and delivered more than 1,000 lectures in India and abroad. He has been ex-president of IIDville Maharashtra branch, 2017 awarded with lifetime achievement by IMA Mumbai. In 2018 he was awarded with lifetime achievement IIDville Maharashtra. In 2019, best practitioner by National and International Conference of Dermatologists. He has been facilitated for IIDville fellowship program Dermacon Pune, and the first dermatologist to start fluconazole therapy in dermatophytosis. So over to you, Dr. Saple sir.
Thank you, Vijay, for a nice introduction. I think today all dermatologists across the country, we are progressing into what is called molecular therapy or molecular targeted therapy. And one of them is JAK inhibitor, that is Tofacitinib. Today we are going to discuss what is the prospect of Tofacitinib in our country, when to use, how to use, what are its limitations. So everything we are going to discuss, and for that we have a wonderful team. Our speaker will be Dr. Chandrasekhar. Chandrasekhar is going to talk on trending concept and treatment in Alopecia Areata. Then we have panelists, Dr. Jaydev Betkarur from Mysore, Dr. Ravi Rathod from Hubli, Dr. Chandravati from Hyderabad, and Manjunath Shanoy for Bangalore. So can you have a slide for introduction? Yeah. Dr. Chandrasekhar is also well known. He is well known for establishing Academy of Cutaneous Sciences at Bangalore. Of course, if you go for his track record, he was a topper in the Mysore University in 1995. He is a fellow of diagnostic excellence. He has organized many conferences. He has awarded the most inspiring dermatology of India in 2019 by Economic Times, and his appreciation award by KN IDL President 2021. There are many publications, and Dr. Chandrasekhar is well known. So we'll have speaker, Dr. Chandrasekhar. He is going to talk. But before you start, I would like to introduce our panelists also. Can I have next slide, please? Dr. Jaydev Betkarur, he was a president, I think the last month only. He has completed his tenure as the national president of IIDVL. He is the treasurer of National IIDVL. What is important about Dr. Betkarur, that he is the head of medical education unit of JSS Medical College, Mysore for last 15 years. And he is organizing secretary for Dharma Mysore 2004, Dharma South 2010, Asticon 2013, and SAD 2015. So Dr. Betkarur is very well known. Now we'll go to next panelist. Our next panelist, Dr. Ravi Rathod from the Hubli. He is a professor and the head of the department at Karnataka Institute of Medical Science, Hubli. He graduated from the Bellary Medical College, and he is the author of chapter on HIV and STD. I know Dr. Rathod and Dr. Jaydev Betkarur become more because of the HIV, because both of them are involved in the HIV management and education. Next slide, please. Next slide, yeah. We have Dr. Chandravati. She is from Hyderabad. She is a professor and HOD Dermatology Care Hospital, Care Institute of Medical Sciences, Hyderabad. Actively participated in various workshops, national and nationals, chairing the program and presenting the papers. She has got 2 times fellowship from EADV and AD. Yeah, we'll go for our last panelist, Dr. Manjunath Shanoy. Dr. Manjunath Shanoy is very well known because he is always there in the limelight whenever any ideal program comes, and most of the program is always there. He is a professor and the head of DVL in Napoya Medical College, Bangalore. He has 97 publications. He is an ex-president of IDL Karnataka, ex-vice president IDL National. And again, if you see, he has organized many meetings like DharmaCon 2015, Dharma Advance 2016, Cuticon KN 2019, Dermophyte 2000. Just mentioned, he has organized, so he is very well known for organizing conferences. So we have the excellent team for the discussion of the Tofacitinib. So I'll hand over, I'll request Dr. Chandrasekhar to go ahead with his talk.
Thank you, sir. Good evening to everyone. So I'm here to talk about experience of Tofacitinib with respect to Alopecia Areata. So in that, I just thought I would give a little bit insight into the recent concepts of Alopecia Areata. So I'll be talking on multifocal Alopecia Areata Totalis. Whatever I talk, it involves only these particular conditions. I'm not going to talk on individual patches of Alopecia Areata. We know that hair loss is an important cause for anxiety and disability. Alopecia areata is an organ-specific autoimmune disease with a genetic background. That simply tells what it is. It's a disease of complex genetic trait. There are a lot of candidate genes have been identified. It increases by tenfold in first-degree relatives. if you look at across the globe, the incidence would be around 2% for the population. There are some critical facts. All of us know about alopecia areata. We have studied from postgraduate days, and in and out we see patients. There are some critical facts and clinical pearls one should look into. When you look into a trichoscopy, probably you can differentiate an acute alopecia areata versus chronic by looking at black dots, exclamation mark here, and yellow dots, which tells chronicity of AA. When you look at nail involvement, maybe it's more common in children, more than 40%, and 20% in adults. If you look at some pits, some patients come and show the nails for pits. You should expect this patient probably to develop alopecia areata over a period of time. It's a pre-runner of alopecia areata. There are two varieties in which alopecia areata patients can shed the hair. When there is a low inflammation, probably it follows telogen effluvium. When there is high inflammation, it follows dystrophic anagen effluvium. Some patients you see overnight, they develop patches. That is dystrophic anagen effluvium, which happens here. Then when you look at the incidence of atopic dermatitis in alopecia areata, probably totalis patients and universalis patients are known to develop AD. We know that alopecia areata is an autoimmune etiology. It's an organ-specific autoinflammatory condition. There are genes identified recently on KDA, trichoalin granules. The autoimmunity is also proved by identifying antithyroid and antiparietal antibodies. We do for that, autoimmune thyroiditis. There are increased O2 species, reactive O2 species, and of course, there is increased stress. This is to signify that is there any other treatment which can be combined with our standard armamentarium to alopecia areata? So alopecia areata occurs because of the breach in the immune privilege of anagen hair follicles, growing follicles. What is this breach? Why do hair follicles have immune privilege? You have two classes of histocompatibility antigens. One is MHC class 1, another one is non-classic MHC. And normally this gets expressed, but in hair follicle it doesn't get expressed, whereas non-MHC gets expressed. There is a local production of immunosuppressants like TGF-beta1. We know it very well. There is a functional impairment of antigen-presenting cells. The plexus around the hair follicle is devoid of lymphatics, so it doesn't carry what is to be carried to the lymph nodes. There is a beautiful extracellular matrix around the hair follicle which prevents the immune cell tracking. Then probably there is an expression of fast ligand in order to delete anything which becomes autoreactive in the follicle environment. All these are the factors which protect hair follicle from having that immune onslaught. When this disruption happens in these mechanisms, alopecia area develops and it progresses to probably alopecia universalis, totalis, whatever we see. These are the new molecular pathways which are disrupted in alopecia areata. Why do you want to study these? Because there are new developments which are occurring in alopecia areata. So you know that HLA-DR is the key etiologic factor. It's an autophagy and apoptosis mechanism. And TGF-beta is one thing. When again the controversy comes when somebody proposes PRP for alopecia areata, the TGF-beta is there. Can it be used as a treatment modality? Question comes. And of course, Janus kinase signaling, that is one of the major development which has happened over a period of time now, where a lot of drugs are coming up and a lot of hopes for alopecia areata patients. So the key inflammatory drivers have been identified as IFN gap, gamma, chemokines, cytotoxic cells, and melanin-concentrating hormone signaling. Is there any proposed screening apart from what we do regularly? Probably you have to go with this screening profile, what I am projecting on a case basis. You cannot extrapolate these particular screening to every patient. Probably you can do a CRP, ferritin, zinc, vitamin D3, then probably autoimmune etiology, ANA profile, VDRL, all these things you can do. And when you are looking at a special variety of alopecia called diffuse alopecia areata, when you send it for biopsy, for an obvious reason that you are not able to identify a diffuse alopecia areata versus chronic telogen effluvium, then probably the biopsy would show psoriasiform dermatitis in diffuse alopecia areata. What are the prognostic points we have learned and we have identified? There is always a negative impact. That means this patient is going to do badly when he has got a large surface area of involvement. There's a long duration of alopecia areata. When there's a nail involvement, when there's a comorbid disease like autoimmune thyroiditis, or you have atopic dermatitis, etc., or vitiligo, then rapidly progressive alopecia areata, then also you should be able to see that it's a negative impact. Patients with regenerated vellus. Normally in alopecia areata, we see the non-pigmented hair coming up. And if you see only vellus follicles over a period of 1.5, 2 months, 3 months after initiating, probably this candidate would not do well. There are some relevant statistics of importance to know when we initiate the therapy for alopecia areata. The patchy alopecia areata, the spontaneous recovery is only 30 to 50%. Probably at the end of 5 years, it could be 66%, but rate of relapse is high. We also see in our clinical practices around 85%. Disease appearing before puberty, chances of developing alopecia totalis is 50%. After puberty, the chances is only 25%. Prevalence of alopecia totalis within 6 months of onset of alopecia. In adults, it is 33. In children, it is 16. Means children are more protected to develop alopecia totalis. Probably when you look at alopecia totalis patients, where they come, go, they come, they do window shopping, because it is 75% of the patients, it's chronic. Only 22.5% would go for a partial remission, but a total remission is really a very, very meager of 2.5%. So all clinicians have to think on this particular basis when you are doing an aggressive treatment for alopecia areata, or you justify. That is the question which comes. Okay. Then when you take AT-AU ratio, periods of regrowth, we see this: adults 34%, children 44%. Complete permanent regrowth, probably it is 10% more in adults and less in children. Refined facts of treatment, when you're talking about giving this chronicity of alopecia, where you need to inject more and more of trams, probably the safer limit would be around 500 milligram. More than 30% surface area, if you find, it is systemic therapy. In my practice, if I see any patient who comes with more than 3 patches, with more than 3 centimeters square area, I always prefer a systemic therapy, because it signifies, it indicates that this is inflammation occurring across the scalp, across the hair bearing area, that you should mind. Then, of course, in foreign countries, they have an intravenous methylprednisolone therapy. But in India, we're very comfortable giving a pulse therapy or a weekend therapy. Then clobetasol foam has come. It's not available here yet. Then SADBay, DPCP, DNCB. But the latest one, excimer laser. Of course, if you have an excimer lamp, it really gives an advantage for you to treat alopecia areata patients. Similarly, you can do NB, UVB, then fractional erbium glass. We know about topical anthralin, minoxidil. Probably it increases the anagen phase, brings out the hair in alopecia areata quickly. But there is one paper which also tells minoxidil has got an action on lymphocytes, but it was not extrapolated by other studies. Cyclosporin is a wonderful drug. As it grows back the hair quickly, if you stop it suddenly, it comes down in the same way. So it is not a drug to be used in a chronic alopecia areata. Then PRP, of course, this is what the expert says. Till pursued as a treatment, it is primarily of a commercial interest, needs clinical validation, and that's not there still. Further, expert opinion says that proposal of PRP treatment for alopecia represents an intellectual going backward intellectuality, not the forward intellectuality. That means to say PRP has to be tested further and further and further to make it an armamentarium for alopecia treatment. Criteria for alopecia areata treatment. Remember these facts. You should always check remission rate should be superior to spontaneous remission rates. When you initiate a treatment plan, you should always think what is auto remission which is happening in these patients and what you are inducing remission. So that should be kept in mind. Proof of efficacy minimal in half set of treatment. Whatever we are doing for Alopecia areata, universalis, and totalis, I openly believe myself that the proof of efficacy is minimal. We know that this is going to recur, but still we treat. Why we treat, we'll debate. Good safety profile with minimal toxicity is the key for the treatment of alopecia areata, which runs a chronic course. How do you design your treatment plan? Probably it depends on the patient's age. It depends on the surface area of involvement, whether you want to go topical, whether you want to go systemic. Duration of the disease process, yes, it's long duration process. Even if it is a single patch of long duration, there's no point in giving a topical therapy because you must have tried intralesional injection, which has not grown alopecia hair back. You have to consider comorbidities and you will have to consider cost factor because when I started Tofacitinib in my practice for alopecia, maybe about 4 years back when we produced the first paper, the cost of Xeljanz, which was available, was around 56,000 rupees for one small course of 60 tablets. So that's what means. Of course, now it is economically available. So the critical appraisal with treatment plan, if you have a single observation case, single reports, taking such a huge risk of pushing your patients to a high-end therapy with a high-cost therapy, I think one has to think. One has to think about it. So current therapies on targets, as Saple sir was telling, that is the era of targets, molecular therapy. So you have abatacept, then you have anti-ILN or RB, then you have JAK inhibitor, which we are going to concentrate today. In emerging therapies, finding appropriate is probably available options. Currently, what you look at, probably a JAK state pathway, which is one which has come. See, if you look into a trichology as such, most of the treatment are serendipity treatments. Take minoxidil, take finasteride, dutasteride, serendipity. So that's how this exactly happened with JAK inhibitor also. They are very promising as they can simultaneously target multiple pathogenic pathways. So these are the ongoing interventional clinical trials available across globe. You have Tofacitinib, we have Apremilast, which is not that promising. Then you have Ruxolitinib, which is probably initially this breakthrough came with oral Ruxolitinib. Now they tried the topical, which was not effective. Abatacept, then all these biologics, new variety of intralesional steroid, then IL-2 methotrexate we use, biocellular regenerative therapy has been used like PRP, and all these things have been tried. And interestingly, the irritant potential of garlic concentrate can bring the hair growth. There is a trial. Apremilast, there are two studies. One says that Apremilast worked well in about 26%, but again, another study said absolutely no use. Maybe if there are reports of Apremilast working on alopecia, I would think that it's a spontaneous remission which is set in, because I have also used Apremilast in my practice, but I don't believe that it works on that. Statins, of course, it came as a big breakthrough. Maybe when we had been to a World Congress of Dermatology in Toronto, but probably there they made an attempt and ultimately they said that it is ineffective. Other newer molecules like fumaric acid esters, we know that this is being used in psoriasis. If you take atopic dermatitis on one side, psoriasis on another side, alopecia on another side, more or less the same interleukins cross through, all at a different level. So many medicines which are used there would also work here. Abatacept, dupilumab, then the tralokinumab and ustekinumab is also because there is a pathway of alopecia areata going through IL-23 to IL-17 where secukinumab and ustekinumab works. BNZ1, of course, this is a new molecule which is on test. We'll have to check because it inhibits a lot of cytokines which are involved in alopecia areata. Crisaborole is an antiphosphate diesterase A4 inhibitor. The report was supposed to come in December. It has not yet come. So let us look into the Janus kinase inhibitors. This is where we have to spend our day today. And what are JAKs? JAKs are intracellular enzymes which transmit signals arising from cytokine. Take a cell membrane. There is a receptor. There is a cytokine. Signal comes in. It gets translocated by JAKs. It's an enzyme. Then it goes to STATs that carries this transducer signal that will go to the nucleus. Either it gets a nuclear expression or goes for a modulation. This is very, very simple. Probably when I show the schematic diagram, you would understand it better. And there are a lot of JAKs available with JAK 1, 2, 3, then TYK2. These are the different JAK family. And similarly, you have stats, which are 6 in number, 1, 2, 3, 5A, 5B, and stat 6. As I told you, it was a serendipity that in 2013, Xing et al. Tried oral JAK1/2 inhibitor ruxolitinib for myelofibrosis, but that patient had alopecia areata. When this report came, for this as well as for vitiligo, it made a huge impact. And I started especially believing that, oh, there is one magical molecule, which is because even when I show that photograph of vitiligo, you will believe that later. So it's a dramatic remission. That's why it came as a serendipity. This is exactly how the molecule works. See, before JAK inhibition, this is the signals, antigens, cytokine get presented on the receptor, as I told, activates JAK. Then phosphorylation takes place, activates stats. There's a signal, transducer signal, which gets into intracellular space, either to modify gene expression or to modulate. This is how it works. When JAK is given, this blocks this proteins here. So there is no phosphorylation. There is no messenger which will be carried by the stats. It becomes inactive and there's disruption. You don't see the outpour of cytokines. Here you see outpour of cytokines, that's how tofacitinib works. So we'll go into tofacitinib. Of course, it's a severe alopecia areata. This is ruxolitinib, tofacitinib of 175 patients. Then the paper came in probably 2019, therapy in children with alopecia, where we are also trying in our clinic. Then there was a treatment variant of 90 patients in 2017, where they studied the long-term effect. What are the obstacles for JAK inhibitors? Initially, the obstacles were, as I told you, the cost. It was very, very expensive. So patient has to spend lakhs together. Now it is not the case, where the patient used to spend 56,000 rupees. Now they get a 1 month therapy in a matter of 2,500 to 3,000 rupees. Sustainability of treatment results. This is what we are going to debate. Liability of the physician, whether it is worth trying, because we have the molecules, we have steroids one side, we have methotrexate, cyclosporine, but how are you going to, introduce this into your armamentarium? They are within our reach now, because a lot of companies have brought out JAK inhibitors. They are within our reach. This is what the case studies, the first case study on probably this was a psoriatic plaque which got cleared. And probably you see wonderful growth on the psoriatic patch initially before the other hair grew. Then the other hair started growing. This is growing. This is what they saw. And there is a wonderful response on eyebrows and eyelashes in this patient. In the second study, they tried it on a patient who had a psoriasis with alopecia universalis. You can see the photographs. It's a wonderful growth of the hair. Then one of the area where they started looking at the pits on the nails for alopecia totalis universalis patient, the pits also got improved, telling that nail improvement would also come. Probably the same extrapolation can be done on a nail psoriasis. We'll have to check. Then this is again one of the Jabari et al. They found extremely good results, and in a week-wise photographs you can see. Probably this is a baseline at week 4. You can start growing here week 8. By week 12, I think almost it is completed. This is our presentation. We reported the first case reports in India from Cutis. We reported the 6 patients. This is what the patient had a dramatical magic improvement, not only in the eyebrows, but all the full scalp. This is what dermoscopic pictures. You can see those terminal layers emerging out of it. This is what we started. Of course, we gave details of 6 patients in that journal. Mean treatment was 3 to 6 months, and that's a significant growth in all patients we tried initially. Of course, relapse was there in 2 patients. So what are the prescribing guidelines for tofacitinib? Start with 5 mg BD, or you can also start with 5 mg OD. I have gone up to 20 milligram, where the patient showed a partial response, increasing the dose, monitoring them, has proved a result, then either taper gradually or abrupt withdrawal on patient's condition. Abrupt withdrawal is not a good idea. Today evening at 7 o'clock, I saw one patient who was on tofacitinib 5 milligram weekly twice, maintaining his alopecia totalis and universalis beautifully regrown on beard area, and it's maintaining from almost 8 months now. So tapering is the probably idea to go about. There is a drug interaction with CYP3A4, ketoconazole, fluconazole, rifampicin, azathioprine, cyclosporin. The normal drugs what we use, we need to have a thought process on these particular interactions. Contraindications will be active tuberculosis. Of course, this is a small molecule which exactly behaves like a biologic. So you'll have to be careful about it. Look for opportunistic infection. Pregnancy lactation, not yet proved to be safe, although it is a category C drug in pregnancy, and severe hepatic impairment. So what is the status of COVID-19 and JAK inhibitors? Of course, hold JAK for 1 week after each vaccine dose. That's what they say. During active COVID, we don't give the drug. No modification to vaccination timing when you do this. There are a lot of changes which takes in laboratory values. I think probably that I'll come to a little bit later. And ruxolitinib is another one inhibitor which is supposed to be almost about 4 to 5 times powerful than the tofacitinib. This is what was tried, and they gave a good improvement over tofacitinib. And now, this is what we have for our alopecia totalis and universalis patients. All of us use these molecules. I made this table to make it understand exactly where are we standing with these JAK inhibitors. So the cost, oral minipulse is 120, methotrexate is 200. This is all per month, and cyclosporin may be 6,500 to 13,000 rupees, and JAK now it's available between 2,500 to 5,000. All are unpredictable with respect to duration because tofacitinib is under evaluation. On-off treatment, it is possible. I have done with tofacitinib also. Maintenance therapy, yes, it requires tofacitinib under evaluation. My patients are maintaining with a low dose. Outcome appears to be very good when compared to these molecules in a very short duration. The onset of action is very fast. The bringing out the hair is very fast. That is what it stands out from methotrexate and oral minipulse. Cyclosporin, of course, it also gives a rapid result. Side effects, because it's a new drug, we'll have to wait because we know the other drugs, what it produces. Investigations, yes, it is not required, not many for a steroid, but for all others, we'll have to have. Then rebound phenomena, oral minipulse, not so dramatic, but with cyclosporin, very dramatic. And of course, JAK inhibitors, we are understanding the concept. We are understanding the situation now. FDA approval, none of these are FDA approved for alopecia totalis and universalis. Whether topical JAK inhibitors work here, that's a question which comes. Topical ruxolitinib was tried, but it was a failure. Probably it got improvement on the eyebrows, but on the scalp it did not. So the judgment has to come still. And the new thing is a sublingual tofacitinib for alopecia areata. Because it bypasses the first pass metabolism, it has to go with CYP. Thereby, probably the effect comes quickly, the dosage could be less, side effects could be less, and probably duration would be less. All these are happening with sublingual. This is a recent publication in September 2021. Probably the half-life, which is normally said in the first bypass, is around 3 hours for tofacitinib orally, but sublingual it is 11 hours. That means probably even at a low dose, it works better. So let's see. Because tofacitinib has been used from 2 milligram to 40 milligram. Even in dermatology also, they use it. So my experience with tofacitinib, as I told you, of course, I have put tofacitinib in more than 100 patients, but a clinical data of a successful treatment. What do you mean by successful treatment? The patient has come for follow-up. The patient has taken the drug for minimum 4 months. That's how. So we around 75 to 80% of the patients do respond. This is our first case of tofacitinib, which gave me a lot of confidence to try this molecule. This is what happened over a period of 6 months. This is probably a dentist from maybe from, I think, Rajasthan or Gujarat. He accepted that he wants to have this treatment. This is how all these patients, what I'm showing are plateau cases. They have tried oral mini-pill steroids, methotrexate, cyclosporine. Failure of treatment I have taken, not the improvement treatment with those. These are the initial cases. This is case 3, a beautiful regrowth, wonderful regrowth in 4 months, beautiful regrowth in 4 months, 6 months. This is not so good. See, the frontal area, there's no regrowth. You see, this you can expect. This is again not a good response, because you see this patient developing full growth in 4 months. This patient, even after 4 months, you see this growth. I think here, what I told you, I have increased the dose up to 20 milligram, but still I am not able to. What does it say? It says that this particular patient, Alopecia areata, having some sub-pathogenetic process, which is not exactly going through JAK and STAT. So that is the inference which you get when you see no response. Absolutely no response. Patient took 6 months of treatment. This was in the era of Xeljanz. This patient is an IT professional. He tried this for about 6 months, spending 2.83 lakhs. The question comes, what is the accountability which I have? So we'll debate it on that. So food for thought, the options available for adopting to the disease. I mean, this is applicable for Alopecia Totalis and Universalis. It is my statement. Options available for adopting to the disease rather than treating it to cure. Probably that we should think in hopeless cases rather than pushing them for a lot of treatment. So let us quickly go into tofacitinib in dermatology. These are the conditions, these are the cytokines, chemokines, and this is the STAT pathway, this is a JAK. Various disease processes have got this. Okay, Alopecia areata, it is possible. Atopic dermatitis is possible. Psoriasis is possible. Vitiligo, it is possible. Then lupus erythematosus, it is possible. So you have on one side the receptors, one side you have chemokines and cytokines, another side you have JAK and STAT pathway, which recognizes these particular diseases to happen. You can use tofacitinib. So these are the various tofacitinib molecule available: ruxolitinib, tofacitinib, citrate, tofacitinib plain, baricitinib, and upadacitinib. These are the JAK molecules with interleukins, and this is how probably we choose the JAK inhibitor for a particular disease. So what are the indications? Psoriatic arthritis, psoriasis. My rheumatology friends are using tofacitinib in and out now for psoriatic arthritis and rheumatoid arthritis. Alopecia areata, as I revealed the fact, atopic dermatitis, vitiligo. There are anecdotal reports which are used in lupus erythematosus, dermatomyositis, chronic actinic dermatitis, erythema multiforme, hypereosinophilic syndrome, cutaneous graft disease, pyoderma gangrenosum, lichen. I think you have a lot of indications to try this molecule out. You can try this molecule out because my experience from past 3 or 4 years, I haven't seen any serious adverse effects so far. I have used in many number of patients, more than 150 to 200 patients. Of late, I have started using in vitiligo also. This is the psoriatic study. Of course, it's a good improvement with DLQI. This is again another study where they compared etanercept placebo versus tofacitinib. Probably tofacitinib appears to be working well ahead than the etanercept, 10 milligram of tofacitinib. In psoriatic arthritis, this is the paper which is produced. Again, it was a placebo adalimumab versus this one. You can see at the end of 3 months, tofacitinib is scoring over adalimumab as well as placebo. Even at the end of 12 months, adalimumab is closing very close to that, but still tofacitinib appears to be better. In vitiligo, this is the wow explorative information which came first on tofacitinib in 2015, thinking that probably it is very good for acrofacial vitiligo. That's where it attracted a lot of dermatologists across globe to try this molecule in these conditions. This is what happened in vitiligo. There are a lot of people who are trying. There are papers which are coming, reports are coming. We have also started. I'm not able to tell my experience as of now because we need to wait for 3-4 months. This is also a vitiligo patient. And at atopic dermatitis, of course, there's a wonderful clearance of atopic dermatitis. Again, I told you, one single drug cannot fit everyone. So we need to check which are the subset of patients who really get improvement with tofacitinib or JAK inhibitors. This is again a case of atopic dermatitis. Luckily, probably this patient also has vitiligo, also seem to have psoriatic plaques or atopic plaques, then it's cleared well. This is one patient with alopecia totalis going for unilateral along with atopic dermatitis. So one drug, two diseases, one stone, two birds. So this is improved nicely. So we need to identify these subsets. Dermatomyositis, it has been tried, given results. These are all case studies. Remember, these are not case control studies. These are case reports. Actinic dermatitis, there's a near complete clearance. Cutaneous sarcoidosis, there's a complete remission in 4 months. Pyoderma gangrenosum, out of 3, 1 patient has a complete clearance. Then what about safety and consideration of tofacitinib? You should adverse effects. One is infections, malignancy, gastrointestinal, laboratory abnormality, hypersensitivity. Infections, you'll have to worry about all these infections. And please think about tuberculosis in India. You have to screen the patient. Malignancy, of course, melanoma, NMCs. If the patient has got gastrointestinal narrowing, pyloric stenosis or diverticulitis, or he is on NSAIDs, you have to be careful about this in perforations. Laboratory, there are hematological reversible abnormalities which occur. We have to monitor them once in every month, once in 3 months. There can be hypersensitivity, urticaria. Of course, I haven't seen any of these things happening in my patients. What about pregnancy and lactation? Pregnancy, it's a category C drug. You'll have to weigh the benefits versus risk. In lactation, of course, you know that the off-life of the drug, the first order pass, then 6 half-lives if you calculate. Probably if somebody is lactating once or twice a day, probably they can use this drug still. Then use of special population, pediatric population, we have started using in pediatric population. Of course, we will be presenting our data probably in a due course. Geriatric population, there is a lot of polypharmacy and a lot of, prone for malignancies. You need to be careful in these patients. Nevertheless, I've tried in elderly also, there's absolutely no issue. As far as these are the contraindications like active infection, positive serology, hematological abnormalities, severe hepatic impotence because it goes to CYP3, then hypersensitivity, tuberculosis, chronic lung disease, interstitial disease. So these are some of the contraindications, not exactly absolute, but you will have to be careful to consider during therapy. These are the monitoring guidelines, the basic complete workout on blood, kidney, hepatic, then rule out HbA1c anti-HCV because it is supposed to activate this. Testing for tuberculosis is mandatory, like biologics, HIV status. After 1 month, the routine test. Then once in 3 months, you'll have to do all this. So to summarize, tofacitinib holds a significant potential to broaden the treatment options for dermatology. It induces rapid improvement, especially in alopecia areata, which I show you through clinical scenarios. It has been comparable or better than etanercept and adalimumab in certain cases. Oral route of administration makes it easy. Compared to other immunosuppressive drugs like methotrexate, cyclosporin, azathioprine, have shown superior results. Definitely, it's a superior result. Tofacitinib was helpful for many patients whose conditions were refractory. Of course, initial 6 cases what we took were all cases of refractory alopecia. Tofacitinib appears to be a possible candidate for treating many dermatology conditions as it's easily available, cost has come down, safety profile is getting proved, and the results are extremely good in alopecia. So this is from me. Thank you so much.
Thank you, Dr. Chandrasekhar, for such a comprehensive talk about alopecia areata and tofacitinib, and especially sharing your own experience, which is really useful for or most of the dermatologists in their practice. Now we'll go for the panel discussion. I think I'll start sharing my slides for that. Yeah. Dr. Jaydev is there. Dr. Jaydev?
Yeah, I'm there.
Oh, it's very good because you're busy with the, yeah.
No, I joined almost 15, 20 minutes back.
Okay, sorry. Yeah. So we'll start with, because Dr. Chandrasekhar has covered almost everything. But Dr. Jaydev asked, what are the indication we can use, where we can use tofacitinib?
Yeah, I think is that I would prefer to use it in all those non-responding cases of vitiligo and alopecia areata as a initial this one. Maybe atopic dermatitis, I may not use it right now, and psoriasis, I may wait for some more time. But alopecia areata, especially not responding to all those drugs that we are trying, like oral steroids and methotrexate and whatnot. So I would definitely try and start using it. I've just used it on a vitiligo patient as of now. The patient says the lesions have stopped spreading as of now, because in her case we tried everything possible. So she was responding and again recurring. So she has said that the new lesions have stopped appearing, and repigmentation as such has not been there. I am yet to use it in alopecia areata. There are 2-3 candidates right now. So we are working it out, the economics of that, and so on and so forth. So maybe I will try, and maybe after another 2-3 months, I should be able to come back with some experience with this.
Thank you, Dr. Jaydev, for sharing your experience. I entirely agree with you. Initially, we have to be careful. We just should not, just because the new drug is there, you should not get impressed or you should not get fascinated. Please go slow, whatever you feel that when you have confidence. And entirely agree with you. There are like psoriasis, vitiligo, atopic dermatitis, alopecia areata, but there are many more indications. Most of them, what is mostly the inflammatory dermatosis, this drug can be used. So we'll go for the next, Dr. Chandravati. Yeah, are you there? Yeah, Dr. Chandravati, are you there?
Yes.
Yeah. So I'm just presenting this. This is a patient of mine, 45-year-old male patient with a chronic plaque psoriasis. He has got comorbidity like diabetes, hypertension, and is treated with Telma, Tyra, and Numlo tablets. Was started with the topical therapy, but there was no response. So we started this patient on cyclosporin 100 milligram BID. But the patient's creatinine started rising and blood pressure started rising. So how you are going to manage this patient?
Since the patient is diabetic and hypertensive, and when you kept the patient on cyclosporin, the blood pressure is rising and the creatinine is rising. My advice for this patient, I will try narrowband UVB therapy plus oral isotretinoin, like oral isotretinoids. Yeah, retinoids. I think these are good for this patient having this diabetes and hypertension.
What we did, we started this patient on methotrexate, but the patient developed bone marrow suppression. So because of that, now the question is, what are the other drugs? Like you said about the acetretin, but about cholesterol we have not mentioned, but usually this patient of hypertension, diabetes, they're associated with the dyslipidemia. So what is the other drug you can use it?
You can, we can use mycophenolate mefetil also, sir, in this. And other thing, yes, we can go with the tofacitinib after doing all these investigations, but there also in tofacitinib also, it can cause hypertension. That you have to look for it.
Sir,
and hyperlipidemia and hypertension, these two are there as a side effects.
Sir, why it was not tried with apremilast, sir? You did not tolerate, because that would be one of the choice for such comorbid patients.
Yeah, but no, because I agree, apremilast is one of the very safe drug. But as you mentioned, you want to talk about alopecia areata, I also got the same experience. I'm using apremilast as a maintenance therapy than the initiation therapy. in most of the inflammatory disease, whether it is alopecia areata or psoriasis, but somehow I did not get any initial report with apremilast, and then we found apremilast is good for the maintenance therapy. So that is the experience we have. So we are using apremilast as a maintenance therapy, because so we have to go for, see, any inflammatory disease, I always feel we have to hit it hard and early. So better to use for the, so we started this patient on Tofacitinib. We started this on patient on, and within 4 weeks, if you see, everything has disappeared. But then,
Sir, why the biologics were not used in this patient?
pardon? Yeah, because
Biologics.
of the cost. Yeah.
Cost.
Yes. Right. Yeah. There are many options, but in this patient, because the cost we should not use. The next question comes. This question is to Dr. Rathod, because then we started treating this psoriasis with a tofacitinib. They said, can tofacitinib use as a rescue therapy? Because we know cyclosporine is one of the wonderful drugs for the rescue therapy. So can you use tofacitinib as a rescue therapy? What is your experience?
So I have not tried it much in psoriasis so far, because, sir, as you mentioned about the patient you are talking about, if the serum creatinine levels, although they have increased, if they have not increased to the level of more than 30% of its baseline, and if the blood pressure has not gone up too much, because they are all reversible, I think if that situation has not arisen, you could have reduced the dose and could have continued, because if you are getting a result, because cyclosporine is the crisis buster, and that is the best drug available so far for immediate control of the disease. As you said, hit early and hit hard. However, if there are conditions because of the side effect where you cannot continue, I think next to that, it is only the tofacitinib which is going to come to your help. Because most of the other drugs, whichever we are trying, take a little longer time, including you're talking about apremilast. It takes at least 2 to 3 months to act, to get a result, or whichever other drugs. So all rest of the drugs do take some time to act, except the biologicals, which may give a better result. I think because of the high cost of biological therapy, and Dr. Chandrasekhar rightly mentioned, because tofacitinib is not inferior to the adalimumab or infliximab, which is being tried. So it is. I think it's going to be quite useful drug over a period of time. You can say from benches to bedside. So the whatever we are learning about the pathogenesis of almost all the conditions what has been mentioned, it is more of a targeted therapy. So I think tofacitinib, cyclosporine still is the best choice, but if there is a contraindication for it, tofacitinib can be used as a rescue therapy.
Sir, can I add a point, sir?
Yeah, definitely.
Yeah.
So normally when we are looking at these patients who are elderly comorbidities, whatever the first line of treatment to induce the remission we start, either a cyclosporine or a methotrexate or a tofacitinib, so it's worthwhile introducing apremilast once the remission starts coming down, so that we can take off cyclosporine, take off methotrexate. If that patient start responding to apremilast, that is one of the best use of apremilast what I have seen in my practice. And the
Chandrasekhar, I do agree. I think as the patient starts getting response, concomitantly we can start apremilast.
That is the time we introduce apremilast, test whether
apremilast along with the rescue therapy. Yeah, that's a good idea.
I think I entirely agree with all of you, because apremilast can be what I was talking about, the maintenance therapy. Because if you start apremilast, you can definitely reduce these drugs very easily and early compared to just continuous drugs. Entirely agree. In fact, I was talking with the hetero. Must come out with the apremilast, so your basket will be full. Yeah, that's so good. So about the rescue therapy, like a biological. So this is one of my patient with the highly inflamed lesions, and after tofacitinib within 2 weeks, because there is a question whether can you use as a rescue therapy like biological or cyclosporine. So according to me, what is our experience, we can use it. So we'll go for the next question. This is the patient to Manjunath. Manjunath, this is a 62-year-old lady presenting with this pustular psoriasis, history of the diabetes and the hypertension, but because severe with the fever and toxic, we are admitted and treated with the systemic steroid with the antibiotic with the control of diabetes and blood pressure. She was on 40 milligram of prednisolone. So how you are going to manage this patient? She responded with 40 milligram.
Yes. Am I audible, sir?
Yeah.
Yes, sir. Normally in pustular psoriasis, although we often tend to use very aggressively initially with steroids and all, my general belief is that the acitretin, it works generally well.
Yes.
And that's one drug. The second drug I would be looking for is methotrexate, because both these drugs can be given in diabetic and hypertensive patients. In fact, methotrexate is also generally well tolerated drug. But only things we have to give a sufficient dose. Yes, when we give a steroid, obviously the response is very fast. But at the same time, it becomes real difficult to taper. Whenever we try to taper, then often they relapse badly. So I usually, if there is no such reason, unless this patient may probably justify in this patient usage of steroid, but often in generalized pustular psoriasis also, majority of the patients I don't think I had any issues in acitretin. Of course, we cannot expect a great result. They may require a much longer stay in the hospital. So my drug will be acitretin and then methotrexate. These are the two choices. Yes.
Thank you, Dr. Manjunath. I entirely agree, because pustular psoriasis is the problem of the flare-up. When you reduce the doses, they get flare-up very easily. It's very difficult to treat. Apart from the biological, I think that day we were discussing about the new biologicals, but that till it comes, I think, so we started with this. And then I said, why not to try this Tofacitinib? And this patient, we started reducing the dose of prednisolone by adding Tofacitinib, 10 milligram BD initially. And then after 2 weeks, everything has disappeared. And now we are giving only maintenance dose for last 6 months, 5 milligram Tofacitinib. And I think, as you said, methotrexate, definitely they are there, because previously you used to use it. But I thought I'll share this patient for last 6 months. She's doing very well with the Tofacitinib. So we'll go for the next. Yeah. So all this trial, Dr. Chandrasekhar has shown you about the trial, about when you use the higher doses, the results are better. That is 10 milligram instead of 5 milligram. Of course, he said it is non-inferior to etanercept, as Dr. Rathod has mentioned. So this is one of the good drugs. So we'll go for the next patient. This patient, I'll go to Dr. Jaydev. Dr. Jaydev, this is a 35-year-old female. She came with a dry, scaly lesions, lichenification, excoriation, and a lot of dandruff-like things with the comorbidity of hypothyroidism. She is on Thyronorm. She has a history of hay fever, asthma, and skin biopsy we did prove it's atopic dermatitis. So this patient we started again as a topical, but there was no much improvement. So can we use immunosuppressant in this patient? Dr. Jaydev.
Yeah, but any other oral drug was tried? Because we have, I think, only topical corticosteroids.
Yeah, topical, yeah.
What was the response with this? No, what was the response with this?
Corticosteroid, salicylic, moisturizer, the patient was not happy. So would like to start systemic drug, any immunosuppressive drugs in this patient.
Yeah, I would like to, maybe I think I would start this patient on cyclosporine rather than try methotrexate or anything. That would be a better option for me. But personally, I would definitely would like to, start her on a much simpler oral steroids if the the patient is
So
very much
Dr.
affected.
Jaydev, you would like
So
to
I would
use
start her on
systemic,
oral steroids first,
yeah,
try it, and
systemic
then switch on to some
immunosuppressant you
other
would like to use,
immunosuppressants.
Yeah, so
other
you would like
drugs.
to use it. But this patient Montu test was 18 millimeter. Montux was 18 millimeter. It was strongly positive. So what you'll do? You'll still start immunosuppressive drug in this patient.
Just the Montu is you are
Montu.
giving isoniazid prophylaxis to this.
No, I'm just asking.
No.
Yeah, but
was there any, except the Montu, was there any clinical sign that the patient had tuberculosis?
Stage X-ray was normal. There were no symptoms. Yeah, but ESR was raised, but not that high. Anyway, this patient, we started with cyclosporine, but when you start with because the question is about TB prophylaxis. Of course, TB is very common in our country when the patient is on immunosuppressive drugs or like immunosuppressive disorder like HIV, where we use Isonex as a prophylaxis for 9 months to 1 year. But there are a lot of study. According to those studies, the Isonex is a very good drugs. But one of the studies shows the compliance of Isonex for 9 months to 1 year is only 47 to 53%. So is it a good drug? Because we are giving long term. So what are the alternative, Dr. Jaydev?
For what? For as a TB prophylaxis?
Yeah, because Isonex, they said, according to the studies, the compliance or adherence is only 50%.
Well, I'm not an expert. I'm not very sure about.
Okay, any other panelist, Dr. Chandrasekhar or Dr. Manjunath?
Used. Maybe others can add on to that.
Yeah. So Dr. Chandrasekhar, yeah.
Can I add, sir?
Yeah, definitely.
Yeah, the thing is, see, just based on Mantu, I don't think we can make a diagnosis of tuberculosis, or we can start in a prophylaxis. As Jaydev sir rightly said, chest X-ray. And in consultation with pulmonologist, I have, before starting the patients on Tofacitinib, I said I want to rule out any tuberculosis. Then they said the best way out is instead of getting the expensive drugs investigation done, Mantu and chest X-ray, they have to pursue. In such situation, I believe we have to take the help of a pulmonologist because TB prophylaxis, we are not so much expert in it. So it is better to consult pulmonologist, and accordingly we can take. And in any case, cyclosporine is the drug which is the safest among all immunosuppressants. So I think cyclosporine can be tried even in a patient with latent tuberculosis who does not have any active infection as such.
Yeah. So thank you, Dr. Rathod. But in HIV, we are treating we have treated thousands of tuberculosis patients in HIV, and the Montu test is strongly positive, and the patient is on immunosuppressive drugs. There are likely the patient will go into activation of TB. That's why I said the 18 millimeter. It's not just positive or the moderately positive, it's a strongly positive.
It's a very strongly positive.
Yeah. So because of that, otherwise, as you said, now previously they said chest X-ray, Montu test, ESR, and IGRA test. But according to WHO, IGRA test is not necessary. Chest X-ray, Montu test, and ESR. So these three, and you can take your decision. So because it was strongly Montu test, I said, but then they said if the patient can't take, the compliance is not good, we can give rifampicin daily for 4 months or INH and rifampicin for 3 months. So you can shorten the period where, or rifampicin also, now rifampicin is also available. So this can be given, the patient's compliance is not good. So that is the message we wanted to give. We'll go for the next patient to Dr. Chandravati. Yeah, this is 55 years old patient of mine with a severe atopic dermatitis. We tried all, and he has got a hypertension. He has around angioplasty, but no history of diabetes. And this patient was started on cyclosporine. He was doing very well. But again, there was a question of creatinine and the blood pressure. Then we started this patient on acetatin, but developed dyslipidemia. Then ultimately started his patient on adalimumab. With the adalimumab, patients were doing well. But when you stop it, again, this patient had a problem. Then we start. He had a relapse. We started Tofacitinib. When you started Tofacitinib, I remember the word of this patient, doctor, why you not started this tablet before? Why are you giving him so many other tablets? Because he got relief very fast. But after 1 month, he came after Tofacitinib, patient complained of body ache. So what do you think?
So, sir, as you rightly said, after trying cyclosporine and other drugs, patient is not responding, you have put the patient on Tofacitinib. Usually, the side effects of Tofacitinib, that is like headache or body aches, all those things, they come in the first 1 month of starting those things, the Tofacitinib. So we should look for any CPK levels raised or any other things. Have you seen that, sir?
Yes, yeah, it is absolutely right. So this patient, first let me appreciate your thing. The side effects are usually like a hypertension, rhabdomyolysis. If some things happen, they happens quite early. So early monitoring is very important. Then we did his creatine kinase, it is raised. Yeah, absolutely right what you said.
And another thing is also, is he on any lipid lowering drugs?
No, he was not on statin. Yeah.
Okay.
Yeah. So because we were new to these rheumatologists, they're using this drug for last 3 years. So I consulted rheumatologists and they told me, sir, this is nothing like what you give rifampicin, you get a flu-like syndrome. Many patients, when you start with Tofacitinib, they may get a body ache, they may get a sneezing, they may running nose. So similarly, they get it, because I was thinking of rare complication like rhabdomyolysis, but he said you continue and the things will, and we continue. So I thought I'll share this experience. These are the other patients, they do very well, atopic dermatitis. This is the patient, she came to my clinic yesterday. And this is the question to Dr. Manjunath. This patient is 79 years old with a hypertension, atopic dermatitis. Her investigation, CBC, LFT, creatine, lipid profile are normal. Which drug you will prefer among these? Dr. Manjunath.
Yes, sir. How extensive is the disease, sir? How was the scoring of
I
can only see the
date,
legs.
but she had extensive, yeah. She needed a systemic drug.
Systemic therapy.
Yeah,
I think although aged patient 79, I would have some hindrance in using cyclosporine, but considering her all profiles are normal, the lab profile, I would still consider cyclosporine as my first line in this lady.
She has a comorbidity of hypertension.
Okay.
Hypertension is okay, sir. There's no issue with hypertension. We can always give cyclosporine, but only thing is we need to monitor the blood pressure regularly, and obviously the creatinine should be monitored little more aggressively. That would be my first choice, and then other drugs I would consider in case she gets in some trouble with cyclosporine. That's the way I would look at it. Yes.
I think other panelists, anybody wants to contribute? Dr. Chandrasekhar.
Sir, I would go with Shanai, because hypertension can be managed when we are giving cyclosporine. Once you start looking at the clearance of atopic dermatitis with cyclosporine, you should be ready with a second-line drug in patients who are hypertensive. So second-line drug, either you choose a apremilast or you choose a methotrexate. That's how we have to go, because she's already 79-year-old female. And corticosteroids, no at all, absolutely. So this is probably, my choice will also be cyclosporine, sir, which we can manage hypertension easily. Not an issue at all.
Other panelists, because this is very important. Yeah.
Yeah, I think I do agree with that, because considering her age, you see, say 79, and hypertension is expected in these patients also. So, which can be managed quite easily with all the available drugs with us. So, a cyclosporine followed by either MTX or apremilast as a maintenance dose, maintenance therapy, and of course the topicals, because old age, so moisturizers and topical steroids wherever required. I think that should be sufficient instead of going in for any other drug.
Since we haven't, since we have not used tofacitinib in these kind of cases, we have no experience. Maybe this case was tried with tofacitinib, sir?
That's why I thought about sharing with you. Usually, I agree with you. If there is no choice, we can start cyclosporine and manage hypertension. I agree. Methotrexate, azothioprine, usually after 75. I'll be hesitant. I'll be careful because of bone marrow suppression. Steroid, as you said, mycophenolate, the results will seen after 3 or 4 weeks. Same thing with the apremilast. Acetretin, again, it takes. So usually this type of patients, I've got about 10 patients above 75. I have treated with tofacitinib for 3 to 4 months, and they do very well, because if you go according to the indication, they said after 65, you have to be careful with the tofacitinib. But just like we manage hypertension with cyclosporine, the hypertension, similarly, tofacitinib you start after 70 years. For last 1 year, I'm using in many patients. And if we closely monitor, mostly their CBC, I don't think there is any problem. That is our experience. So I thought of sharing that. I'll show some patient. Yeah. So this is the atopic in vitiligo. This is one of my patient of vitiligo. This is to Dr. Rathod. She had very extensive lesion. She have tried oral steroid, methotrexate, cyclosporine, phototherapy, methoxylin, puosol, narrowband, everything she had tried. She's the daughter of one of my colleagues where I'm using this hospital. So I started with tofacitinib, 5 milligram BID, but after 2 months, there was no response. I think I'll ask Dr. Jayadev because he is treating vitiligo, no?
2 months is, I think.
After 2 months, there was no response. So there was no benefit.
Is a bit too short period. I think you should continue because you have tried everything there in that patient. Of course, you need to have the other adjuvant therapies with NBVD or PUA also along with that. And I think 2 months is too short a period to say that it is not working. You may have to wait for another a month or two, because we have tried everything that is possible.
Thank you, Dr. Jayadev. See, it takes at least 5 months to 20 weeks. That is about 5 months to start getting, as Dr. Jayadev said, 2 months is not enough. And I have conducted many webinars, and the consensus across the country, tofacitinib with a narrowband PUA therapy, I think that gives a better result that Dr. Jayadev already said, the PUA therapy. And that is a consensus across our country that you have to, of course, according to the whatever the literatures and the experience, PUA therapy, and it has to be more than for 20 weeks or 5 months. And sometimes you have to increase the dose. Alopecia areata, Dr. Chandrasekhar has shown a lot of cases. This is one of my patients who had a Alopecia Totalis. And then we started with the methotrexate. She started showing very good improvement, but she developed side effects of methotrexate and she stopped it. Then again, she came with the loss of hair. When she came with the loss of hair, as Dr. Chandrasekhar showed many and beautiful cases with the beautiful pictures, we started tofacitinib. She started doing very well. But the question comes, she is getting married. So what is your advice, Dr. Chandrasekhar?
Sir, it's a pregnancy category C drug till she becomes, she decides to become pregnant. Probably she can continue. And since the half-life of the drug is being 3 hours and the 6 cycles half-life would finish in a matter of 3 days to 4 days. that is 72 to 96 hours, probably she can plan. Since if she becomes pregnant, probably she has to stop it, sir, because there is no much data available on pregnancy. But she can continue till that time, sir.
Yeah.
The washout period is about 1 week, as Dr. Chandrasekhar said, half-life and washout, so you can wait for 1 week to go ahead for her planning.
Shall I give you?
Yes, madam.
Sir, patient, if the patient is married, you can shift the patient to cyclosporin.
I entirely agree. Cyclosporin is the drug we can use before pregnancy, during pregnancy, even after pregnancy. That is a wonderful drug as per the pregnancy is concerned. I agree with you, madam. Yeah.
But a lactating woman cannot take it, sir. Lactating.
So which
pregnancy is okay. Cyclosporin. During pregnancy, it's okay, but if she has to feed the baby, I think it's contraindicated, not given.
Thank you for that. Then this is a patient of mine, Alopecia Totalis. We started Tofacitinib within 2 weeks. So this is a very good drug. But the question is, Dr. Chandrasekhar, I'm asking you because I heard your talk. After that, I was impressed. This is a patient with the loss of eyebrow. We started Tofacitinib. He showed a good improvement. But he said, sir, what about my eyelashes? So what is your impression about that? Because
sir, surprisingly, the patient grows eyebrows nicely, but eyelashes still it's a
he didn't get a
so
growth of eyelashes were lacking still.
Yes, sir. We use a bemetoprost or a latanoprost for eyelashes, and that gives good growth, sir. Along with Tofacitinib, if you do that, it gives growth. And the problem is that this patient also seems to have
webinar medicine.
I agree with you, Dr. Chandrasekhar, but then I went to literature. They said you have to wait, just like a vitiligo, you have to wait for 3 to 4 months, and you may have to increase the dose, but the period for eyelashes requires a longer period. So we thought of sharing this.
No, but what about, I also heard Chandrasekhar talking about the good response, but he also mentioned that there is a chance of recurrence. What is the usual? I'm not aware, but can anybody tell me what is the
Jaydev, thank you for raising this question. That is a big question Chandrasekhar has raised. We can get the hair growth, but what about the sustainability? We are able to sustain it or not? And I think I'll expect answer from Dr. Chandrasekhar or anybody else.
So this drug is a new learning for us. So, because we started using this drug when the cost was very high. We had a very limited number of patients who accepted this particular treatment and they did well. Then we started looking at 20 milligram, then coming back to 10 milligram, then coming back to 5 milligram, coming back to 5 milligram alternate days, twice a week. This is how we have started categorizing patients. At least 30% of the patients on Tofacitinib, the moment you start tapering, they will start losing hair. So that is where the critical issue of accepting the failure of all these modalities for treating Alopecia Areata Totalis has to be taken, and the patient has to be counseled. That's a critical point.
Major issue with most of our patients.
If once you start tapering, if the patient maintains, or if 1 or 2 patches come, that can be retreated with an intralesional steroid and they regrow back. Those are the patients you can maintain them. The question is how long you maintain. When you want to treat such cases, you take a broad look of oral steroids, methotrexate, cyclosporine, Tofacitinib. These are the 4 drugs we have for Totalis and Universalis. So when you take this drug and evaluate this drug on a merit basis, on a quality basis, probably if you look at Tofacitinib scores over others, sir, in my experience, from past 4 years.
Because the response is fast.
Yes, the response is fast. Now the drug cost is very less.
Yes.
And probably, as sir was telling about monitoring, I haven't seen any single side effect so far with Tofacitinib.
Safety profile is good.
Except for acneiform eruptions which the patient developed But apart from that, some mild muscle pain, gastritis, all this. So that is the way forward. Once you feel that this patient is relapsing, recurring, that is the crucial time to take a decision to counsel the patient for weeks and other.
Sir,
Dr. Chandrasekhar, I'll come
I have
directly.
a
What
word.
about the?
Hello, sir. I have a word, sir.
Yeah.
Here it is. The point is, see, all the diseases what we are treating, they're all autoimmune disorders.
That's correct.
So these are going to be there with the patient lifelong. So some treatment or the other is required. I think cyclical treatments is the best way of doing it, sir. Because so that the side effects we can control.
But the question comes, madam, accountability. How long are you going to treat them? Tell me. Are you going to
that's
put them
why
on a
Dr.
drug for lifetime?
Yeah, Dr. Chandrasekhar, that's why I'm asking.
Sir, what is
about the apremilast?
No, it doesn't work,
maintenance.
sir. Apremilast doesn't work. Otherwise, I would have seconded this opinion. See, all these are immunosuppressive drugs. All these have got side effects. How are you going to continue for lifetime?
Correct. That
is
nobody knows how long we should use
nobody
it.
knows, sir. That's the
nobody.
crucial
Yeah.
part.
But I think Manjunath is very active in IIDWell. They should take it, and I think somebody has to. Their study has to be done about 3 years, 4 years. Somebody has to do it. I think Manjunath, I'm just suggesting you.
Yes, sir. Yes, sir. I think that this drug is the way this profile is. It looks like a dermatologist's drug because we have a lot of autoimmune diseases which have a very poor quality of life, like vitiligo. We have psoriasis. So obviously, this drug appears to be a dermatologist drug, but although we don't have even single approved indication, but I think sooner or later, as the evidences pour in, they might get approved. That's
I just want to add on, while you are treating such conditions like Alopecia Totalis universalis, you should start tuning your patients to accept the disease. Sir, nobody would accept that if you say that, no, this is not going to get cured, please don't worry, use a week. You cannot say it to your patients. Sir. You have to treat them. While on treatment, you need to take them into confidence. You need to educate them on the process of the disease. For example, a young girl who comes, who is getting married, probably, as madam said, shift over to a cyclosporin, she'll get a child. Then maybe she'll get matured over a period of time and she would start accepting. And there are a lot of physical modalities available to cover the baldness. This is the way forward. You need to tune your patient for such chronic diseases, sir. Otherwise, there's no way that you can put the patient on a lifetime immunosuppressives. No, that's not warranted.
Is difficult. So we'll go for the next to Madam Chandravati. This is the patient. This patient, he came with. We started with the Tofacitinib for the I think a chronic plaque psoriasis. But his complaint was he came with a history of loss of hair. So what do you think when you look at this patient?
Is it loss of hair after starting the Tofacitinib, sir?
That's why he says.
It is not looking like. It is not looking like the loss of hair because of Tofacitinib. Most probably it is balding there. I feel that.
Male pattern hair loss. No?
Yes.
Yeah, but he came with these bunches of hair, male pattern, we don't see this.
Yeah, okay.
So, do you think is related to Tofacitinib?
No such side effect of hair loss is there with Tofacitinib.
You should think of other conditions where the patient will have to take a history of 3, 4 months, 5 months, what is happening.
Yeah, so Chandrasekhar, we found he had a history of
telogen FOM also.
Yeah, so he had a history of COVID, because of COVID.
Yes.
Yes. See, this is just for the, yeah. Anyway, so there are questions from the doctor, from Dr. Rashmi Singh, when and how to taper Tofacitinib. I think Dr. Chandrasekhar has addressed that. Dr. Sandeep Arsad about the vitiligo, we have discussed that. Dr. Ravi Chandran, what are the investigations needed before starting and during therapy? Alopecia areata, atopic dermatitis, vitiligo. Is a patient you want to start on Tofacitinib? I think Chandrasekhar has covered, but Dr. Rathod, can you repeat? What are the investigations you would like to do before starting Tofa?
Sir, you're muted, sir. Rathod sir, you're muted. You have to unmute.
So complete hemogram,
Yeah.
complete hemogram, LFT, and most importantly, as he rightly mentioned, you have to rule out active tuberculosis or any active infection, herpetic infections, or if the patient by chance is suffering concomitantly with any malignancies, that has to be ruled out. And both hepatitis B and hepatitis C. So I think these are the basic minimum investigation required before we start a patient on Tofacitinib.
Okay, thank you. So all basic what you do for the any immunosuppressant drug, I think we should do it. We'll go for the next. This is for Dr. Jaydev. This is a patient of mine, which is 73 years old with the lichen planus, and she has a hypertrophic lesions. She has given steroid, methotrexate, cyclosporine, azothal, everything was given to her, but she was not responding. So she landed in my clinic. We did a biopsy. Biopsy shows a pseudocarcinomatous hyperplasia, but because nothing was left, we started this patient on Tofacitinib. And after 2 months, see, everything clear. She's 73 years old, everything cleared. But when she was on maintenance, she came with the swelling of the foot, tender, with erythema. So what you can think of?
Well, I think she has developed cellulitis maybe. This is only unilateral? This is unilateral?
Yeah, it's a unilateral. Yeah,
unilateral. So
yeah,
I think she has developed cellulitis. Could be, could
she
be
develops
a part, an anecdotal coincidental occurrence rather than blaming it on Tofacitinib. Though infections are known.
No, Dr. Jaydev, when the patient is on Tofacitinib, they develop bacterial infection and cellulitis.
Yeah, correct, that's what. But it may be coincidental rather than blaming the Tofacitinib in this case, because she is a old patient and probably not,
In fact, because the old, they are more likely to get infection.
Yeah.
And also to rule out DVT, sir.
Yes, correct.
They are likely to have thrombosis. Thrombosis is also a rare.
Yes, correct. But that usually it occurs above the ankle, DVT is more, patient is obese, patient is sedentary. But this patient developed cellulitis. So we treated this patient with the linezolidine, everything, this lesion. So can we start again or no?
Sir, you can start. Sir. You can start.
You can start, sir.
So you can see that the nails is, if you look at that, that's a chronic paronychia, sir. That could be the nidus of infection in this patient.
Yeah.
Carefully look at the nails, the toenail. There is a recession of the folds. So,
we started on this patient, and we are following her for last 6 months with the twice in a week dose, and she is completely under control. And there was no recurrence of the infection. We'll go for the next question from Dr. Naneshwar, Dr. Viresh, 30-year-old patient with alopecia totalis on the antipsychotic medication. Can Tofacitinib be used, Dr. Manjunath?
So which drug is it? I didn't.
Antipsychotic drug.
The last part. CYP3, yes, there is some interactions, but I think I may have to use which antipsychotic, and I will probably use one of these, the interaction checker, and then I think that's the best way to go about it, because antipsychotics do have a lot of interactions.
But not much with Tofacitinib.
They have to think what is the metabolic process of the drug, what the patient is taking. Is it going through CYP? Then probably you will have to be careful. You cannot say that you cannot put a Tofacitinib. You can put, but you will have to see whether it is increases the bioavailability of the blood or decreases it.
I agree, because we have to give you the metabolism, the question of metabolism. As Dr. Chandrasekhar said, that CYP3A4 is the metabolism for Tofacitinib. So any drugs, we have got the same metabolism, either what is called is the enzyme inducer or inhibitors. But antipsychotic drugs, usually they are metabolized by substrate 2D9. So they do not come
Yeah,
in
yes.
this, yeah, except that if you're using itraconazole or terbinafine. Terbinafine is the only drug-drug interaction occur with the terbinafine. Other terbinafine is one of the safe drugs as per drug-drug interaction is antipsychotic, that is not acceptable. But itraconazole, because I take a lot of talk on the fluconazole, and fluconazole is metabolized by 2C19, where it is not metabolized by CYP3A4, so it doesn't come in the interaction. So antipsychotic, antifungal fluconazole can be used, and here tofacitinib can be. Here we should avoid. You should not avoid. It can be used as per a drug-drug interaction is concerned, but other contraindication I do not know. Yeah. Now, one of the side effects is cytopenia. So, when do you expect cytopenia, Dr. Madam Chandravati?
Cytopenia patients, maybe I think with the dosage, increased dosage of the tofacitinib, I think we have to look for, we should be careful, sir.
Yeah,
10 milligrams BD dosage and all that, I think they may cause cytopenias. Otherwise, 5 milligrams BD, it is not causing that much of problem.
Madam,
Yeah, usually
this is commonly found with rheumatologists, not with dermatologists, because rheumatologists go up to 40 milligram of tofacitinib. So with dermatology, maximum we use up to go 20, but with 10 milligram, we can definitely have a 90% of the patients treated with tofacitinib. It's more with rheumatology doctors who see this.
I entirely agree. One of my patients, I was giving 2 BID. Their WBC count went to 3,200. One another is 400. But when you reduce to 1 BD, the WBC count reverted back. So is the dose dependent? As you said, the rheumatology where they're using higher doses. Even about the malignancy is same. You are using higher doses, then there are chances of malignancy. That's why I thought DVD, we have discussed about the DVD. I think any other question for the panelists? You want to contribute your experience? If you're not, then I would like to ask everybody. I'll start with Dr. Jaydev. What is your message for tofacitinib?
Tofacitinib appears to be a good drug, especially for dermatological diseases, where we have been trying so many drugs over a period of so many years now, and wherever it has failed, then wherever we have used and failed, then tofacitinib could be a drug of choice there, but definitely not a drug of choice at the beginning. Maybe once we try quite a good number of drugs, they fail, or there is a relapse and recurrences and so on and so forth, then we can try. But again, as it has been told, we have to wait for the long-term benefit and the long-term side effects of this drug. So experience is less with the majority of us. So as we go further, then evidence may be there, and we should be able to use it more freely, and expecting good results or moderately good results over a period of time. As I said,
you, Dr. Jaydev, for expressing your right view. Yeah. Yeah. Now I'll go to Dr. Chandravati. What is your message?
Yeah, my message is, of course, now the tofacitinib is cheaper, easily available. But I will definitely advise people who are going to use tofacitinib, they should you should follow the caution, all those things, whatever precautions we have to follow, and also do not try as a first line drug. This is very important. First, try our regular drugs. If they fail only, we should go for the tofacitinib, because it is almost equal to biologics. And remember the side effects of tofacitinib, and all those things you must keep in mind, and then go ahead with the tofacitinib. It's a good molecule, but you should be careful.
Thank you. Now I'll go to Dr. Rathore.
Yes, sir. I feel it's a wonderful drug. It's a very good drug for in the armamentarium of dermatologists. And over a period of time, it's likely to replace biologicals because biologicals are prohibitively expensive. And this is the drug which is almost acting in the same. It's such a targeted therapy. We know the pathogenesis and it targets that particular enzyme. So I find that this over a period of time down the line, under a few years, as we gather more information about its safety aspects and its efficacy, more and more JAK inhibitors along with tofacitinib is likely to come. And we are going to see a great change, and our patients are likely to be benefited immensely. Thank you.
Give me the drug for future. Correct?
Yeah, I feel so, yes.
Dr. Chandrasekhar.
It's because I've been using it from past 4 years. I would say it's a very good drug. The clinicians have to recognize the subset of patients where this can be used. It's opening up a Pandora box, because you see report on pyoderma gangrenosum, you see report on chronic actinic dermatitis, you repeat on chronic eczema. So all those conditions which are immunologically derivative, they all have something to do with JAK, something to do with stats, something to do with interleukins. We have to try. We should not discard this drug. It's a bystander drug as on now, because now you know the first line of treatment for psoriasis is biologic now in foreign countries, not the other drugs. We don't know that tofacitinib would take such a place. It all depends on clinicians. How are they going to use it? How are they going to recognize those subset of patients where it can be used care successfully? And of course, taking care. I think we are all not new to immunosuppressants, sir. We have seen in and out, we have used methotrexate, cyclosporin in our practice. It is not a very, very difficult thing to go with tofacitinib as clinicians. You have to be careful and you have to be watchful. That's it. So it's a wonderful drug. It is there to stay with us. We should have
now I'll go to Dr. Manjunath. Yeah.
I agree. It's a good armamentarium in dermatologist basket. As of now, it's relatively new to us. I think we will develop. We are going through the learning curve, and I think in over a period of time we are likely to use it more. But whenever we use it, I like Madam Chandravati said, and Chandru sir used it as a backstage drug. I think we need to mention very clearly why I am using this drug, because we need to be very careful in documenting the reason why I have used this drug. Always mention which drugs have failed in the past, why I am using it. Considering the black box warning, it comes with the infections, thrombosis, as well as the malignancy. So we need to be careful in documenting why I am using this drug. So that's one message I thought I'd give.
Thank you very much. You have given really wonderful your inputs, our experience, and the message is very clear from all of us that these drugs, when you are using it, you have to be careful. Just don't prescribe. Be careful is really indications. And I feel this is the drug for the future. Thank you very much. I think I'll hand over to Hetero Healthcare.
Yeah, thank you so much, sir. It was an excellent program we had after a long time on the tofacitinib, sir. And in fact, we thank you all of them, all the doctors, especially Dr. Saple sir, for guiding us throughout the use of tofacitinib and for this program, and helping us to connect with all the stalwarts here, and an excellent moderation, which he does always. Definitely thank you, Dr. Chandrasekhar sir, for an excellent talk, comprehensive talk, which has cleared a lot of doubts in managing alopecia areata, and also sensitizing about various indications where it can be used. Definitely the expert contribution from our doctors, panelists, Dr. Jaidev Bechpuri sir. Thank you, Dr. Ravi Rathod sir. Thank you, Dr. Chandravati ma'am, and thank you, Dr. Manjunath Shenoy sir, for the expert view and experiences shared during this tofacitinib webinar which we had. It was definitely a talk which must have answered many questions to the all attendees who have attended this, the audience who have attended this webinar. Thanks to their time also for attending this webinar from this busy schedule, and thank all our faculties to give us your valuable time and making this event a scientific treat to all those who are there. Thank you, everyone. And I'll officially close the event.
Thank you.
Thank you so much.
Thank you.
Thank you,
Thank you.
Saple. Thank you, everyone. Good night.
Good night.
Thank you.
Good night.
Good night.
Good night. Good night.